All right, good afternoon. Thank you all for being here, to those of you who are here in the room and to those who have joined online. My name is Angela Hobson. I serve as the Associate Dean of Education at the School of Public Health, and I have the distinct honor to introduce our Talking Public Health speaker for the day. For those of you who are in the room, just to let you know, at the end when we do question and answers, we'll run this mic so our colleagues that are online can hear us well. So with that, I want to introduce our speaker, which is Dr. Matthew Kreuter. He is the Kahn Family Professor of Public Health at the WashU School of Health and the founder of the Health Communication Research Laboratory, now in its 30th year of continuous funding. Dr. Kreuter and the HCRL team conduct research to identify and address health gaps between different populations by expanding the reach and improving the effectiveness of health information and using information technology to help connect people to health and other services they need. Dr. Kreuter also serves as the inaugural co-lead of the Health Communication Collaborative, one of 6 innovation research networks in the School of Public Health. He received his PhD and MPH from the Gilling School of Global Public Health at the University of North Carolina, Chapel Hill. And this is a really brief bio, and one thing that it doesn't get across is how influential Dr. Kreuter is to so many people in public health. And I'm really excited about his talk, which is how healthy is today's health information ecosystem. And I think you'll see through this just how influential his work is to public health research and practice. So with that, I'm turning it over to Dr. Kreuter. Thank you.
Thanks, Angela. Gosh, no pressure there. Good afternoon, everybody. Let me just say up front to all of the faculty and staff and students who are here in the room and who are listening online that we're trying to build a major presence in health communication here at WashU. And if you have interests in this work, if there's anything you hear today that excites you or that is aligned with things that you care about, if you have ideas about how to make this work better, if you have ideas about how we might collaborate to do more together, we want to talk to you. Let's figure out how we can really elevate health communication here at WashU. In my talk today, I want to accomplish these 3 things. First, I want to put health communication in the broader context of public health. Secondly, I want to try to move us away from thinking about health information as, sort of a product or a commodity towards moving towards thinking of it as more of an ecosystem. And then lastly, and I think, most interestingly to me at least, is to explore how WashU Public Health can strengthen and enrich this health information ecosystem. Let's start here with what is public health. So I am a 2nd-generation public health worker. The guy on the right in this picture is my dad, Marshall Kreuter. And when I was a kid, he worked at a state health department in the state of Utah, and then CDC found him and hired him, and he worked at CDC for a while. And at the end of his career, he worked at Georgia State in their School of Public Health. And my dad liked to describe public health as asking and answering these 4 questions that you see on the screen. And I always really liked this, and so I wanted to share it, especially with the students who are following. So public health wants to know what's the problem, who has it, why them, and what can we do about it. The first of these questions, what's the problem, this is the surveillance function of public health. So public health, how does public health know, for example, that we're in the midst of a mental health crisis for young people? We know because we're monitoring all sorts of sources of information. We know because emergency room visits for mental health crises among young people are on the rise. We know because prescriptions for antidepressants and anti-anxiety medications for young people are on the rise. We know because suicide attempts, calls to suicide hotlines are rising. We know because we survey people, young people in behavioral risk factor surveillance system surveys, we know that they are less satisfied and less happy with their lives. And so public health is monitoring all of these things, and when we see something, we raise a red flag. Something's going on here, and we need to act. We need to do something. The second 2 questions, this is epidemiology. Who has it and why them? These are the sorts of kind of disease detective questions that we answer in public health to try to identify the causes, the patterns, the distribution of diseases in populations. And then the fourth question, what can we do about it? This is the action orientation of public health. What are the policies or programs or solutions that we need to put in place to reduce the health impacts on populations? And what I would submit to you is that health communication is really cross-cutting. Health communication appears in every one of these four questions. So when we identify emerging public health problems like we do in surveillance, we have to convey that information to the public and to leaders. That's health communication. When public health science generates new evidence about preventable causes of disease, we have to translate that science into ways that are understandable and actionable to individuals and organizations. That's health communication. And when we put together policies and programs and solutions to address public health problems, almost invariably those involve some degree of engaging people through information and communication. That's health communication. So health communication is baked in to all of these core functions of public health, and that's why you'll find health communication on the list of 10 essential public health services, down on the lower left of this slide, informing the public about public health. This brings me to the first of several questions I'm going to pose to the group. So I want you to think for a minute about how you personally, how and where you get health information in your daily life. I want you to think about that and pick the one source that you think you get the most health information from. Just take a second to think that over. What's the one source that you get most of your health information from? Okay, now raise your hand if the source that you picked as getting most of your health information from was your local county health department. Raise them high. No one. Raise your hand if you thought of your state public health department as the main source of health information. No hands. Okay, so what did you come up with? Let's just shout out some things. What are the, where do you get most of your information? I'll start calling on people. Reddit, what? Social media. Classes. Doctor, your job. So this little exercise, I think, illustrates two really important truths about health communication, and both of them are pretty relevant to this talk today. The first is that although health communication is a core function for state and local public health and federal public health agencies, those agencies' capacity to do it well is extraordinarily limited in most cases. And work here at the School of Public Health, particularly from the Prevention Research Center, has demonstrated that in multiple studies. Secondly, the way that most of us get health information is pretty varied. Like we heard a number of different sources. And those sources exist in what's a highly complex system of health information that I'm going to refer to as an ecosystem. So this is not an exhaustive list by any stretch of the entities that you might find in a health information ecosystem, but these are some of the players that are involved in creating, sharing, and using health information. And all of these different entities play different roles and they fill different functions within the health information ecosystem. So just to kind of quickly walk through some of those, some of these organizations and entities are involved in content creation. They create health information for others. Some are involved in the distribution of that information, getting it from one place to another, getting it to the public. Obviously, there's overlap. Certain organizations can, they can create and they can distribute. Fewer entities are actually involved in generating health data and evidence from which health information emerges. Fewer still are engaged in what we might think of as community listening, trying to figure out what does the public know? What do they want to know? What do they need to know? And fewer still are involved in what we might think of as coordination. So what is the planful, what sort of planful efforts are there to assure that certain information gets to people at the same time or multiple times? I like this analogy of health information operating as a kind of ecosystem, because ecosystems are interconnected, and I think the health information system is also connected. Scientists create evidence, journalists report on it, their reporting is distributed through media, there are connections among all those entities. Ecosystems are complex, so people learn, and you guys illustrated this, people learn from lots of different sources, from media, from friends, from family members, from the internet, from their doctors, and they have to weigh kind of competing and sometimes conflicting information to decide what, if anything, do I do with this, and how do I act on it. And lastly, and this is the part I want to focus on for a moment, ecosystems are dynamic. They're constantly changing. And the health information system is constantly changing. Evidence changes over time. During the COVID pandemic, evidence changed sometimes daily and often weekly. So evidence changes. The sources of information that we rely on can gain and lose credibility over time, or trust. Think about Dr. Fauci over a couple of years. And then technology changes. So we get advances like artificial intelligence that fundamentally change how information is created and shared and used. So let's take a look at some of the ways the current health information ecosystem is changing. I'm going to walk through some examples, but like this is sort of a high-level summary of the changes that we're seeing. First, this is not new, but it's so fundamental. The sheer volume of information that's available is growing exponentially. And we've tracked this, not our group, but scientists have tracked this over time, over decades, and it's just not possible for humans to consume even the tiniest fraction of what's available in the information environment. So ask yourself, what determines the tiny little infinitesimal part of what's available? What determines what you see? Some of it is what you might expect. Some of it is that each of us has personal interests or preferences, and we seek out that information. But a lot of it is entirely outside of our control, and it's determined instead by powerful entities within the health communication ecosystem that control the flow of information, that control who sees what and when. Some of the best work on this comes from William Brady at the Northwestern Kellogg School of Business. And they have shown, for example, that content that's emotionally evocative, especially content that sort of stirs outrage or moral outrage, gets more attention. And that's not because of social media, that's just human nature. So as humans, we pay more attention to things that move us emotionally. Now, add social media to the mix, and what do social media companies care about? They care about attention, because the more eyes, the more likes, the more clicks, the more shares, the more money. And so you have human nature where people pay attention to emotionally evocative content, and then social media privileges and spreads information that captures attention, and so therefore information that's emotionally evocative spreads faster and further. That's pretty well-established science. Now, let's add misinformation into the context. Studies have also shown that the sources of misinformation are actually quite good at evoking moral outrage and other sorts of emotional reactions. And so misinformation elicits the kind of emotion that captures attention that social media then privileges, and so misinformation spreads further and faster than other kinds of information. And there are consequences of this, real consequences. People who are exposed to emotion that to information that stokes emotion and outrage are more likely to feel that the people causing that outrage hate them. So it's very divisive. Feelings of hostility towards others as a result of this emotionally charged information. And that sort of polarization that happens occurs in other corners of the health information ecosystem as well, like news reporting. So from time to time, I'll scan news outlets, different news outlets, to see what they're covering, and I happened to do that on April 4th of this year. April 4th was a Friday, and I did this at 7 o'clock at night. So this also gives you a little glimpse into the scintillating social life of a university professor. But I grabbed 4 screenshots from different websites over the course of 2 minutes. And I just want to show you what I saw. What you're looking at now is the Washington Post headline. This is the headline from the New York Times. Here's the headline from NBC News Online. And here's the headline from Fox News. Now, I make no judgment about which of these stories might actually have greater news value as a headline. In fact, I think I could argue, in hindsight at least, that the focus on the Wall Street decline was a bit of an overreaction. The S&P 500 rebounded entirely within days, and here we are a few months after this, and it's hundreds of points higher. The point, though, is not which is more accurate. The point is that different groups see day in and day out wildly different depictions of the world. And those depictions often villainize or blame people who have a different depiction or a different worldview for what they're seeing, so greater polarization. Add on top of this that in the last 6 to 9 months, we've seen a shrinking of government, which includes health agencies. And within those health agencies, the offices that are charged with communicating health information to the public have largely disappeared. So another critical function of public communication, public information about health, that's now a gap area in our ecosystem. And finally, surveys of trust have been showing for a while now, but continue to show declining trust in public health, declining trust in science, declining trust in institutions. This is a poll from KFF that just looked at 18 months from the middle of 2023 until earlier this year in 2025. And you can see trust in CDC, which was already low, continues to drop. Trust in FDA, lower. Trust in your doctor, trust in local and state public health, all declining. So the health information ecosystem as it currently exists is undergoing major changes on many fronts. And the people who are in that system are currently scrambling to try to sort things out and fill in gaps. And that's what I'd like to talk about for the remainder of our time. What can we do about it? Now, a lot of folks in our field, a lot of public health professionals look at the current situation and identify the problem as, we got a lot of people who are believing stuff that just is not accurate. They're believing false claims, misinformation, and trust in science, trust in public health, trust in what we do is declining, and that's the problem. And there's no question there's no question in my mind that those are problems. But I think that they're really, those are things we should be addressing. I don't know that they're the major problem. I think they're indicators, and I think they're indicators of a health information ecosystem that needs strengthening. So to think about how we might strengthen the health information ecosystem, I want to start by looking at 2 other ecosystems, and we'll start with like my favorite of them all. I love Glacier National Park. Has anyone been to Glacier National Park? Can you raise your hand? Like bunches of people. Okay, so that's great. When I say Glacier National Park, you think of, give me a top of mind reaction. Glaciers, okay, that's good. What else? Mountain goats, love that. Did you just say panda, Doug? Canada. Oh, Canada. Okay, it's up by Canada. I'll tell you what I was looking for. I was looking for bears. I was looking for the grizzly bears that are all over the park. And if you were to think about the ecosystem in Glacier National Park, a lot of people might think, oh, well, bears, grizzly bears are really important to it. And they are, but those grizzly bears actually depend heavily on a particular tree, the white bark pine, which you see here. And this tree is pretty amazing. It grows in very rugged and desolate sorts of environments that are frigid for most of the year. But bears rely on it because of these. These seed cones have inside of them what amounts to kind of a superfood for animals. This would be like walking up to a tree and just having the king-size Snickers bars all over the tree. And so the bears right now are eating as many of these seeds as they can find. They're in what's called hyperphagia. They spend about 20 hours every day right now just eating to store up energy for their hibernation, which starts in about a month. So bears rely on these, and they'll climb into the trees to get the cones, and they'll dig up seeds that were buried by red squirrels or a particular bird. I don't see Joe Steensma here. I want him to name the bird. Joe, anywhere? Okay, it's the Clark's nutcracker. So it's not just the bears and the squirrels and Clark's nutcracker that depend on these trees, but also these trees capture a lot of snow because they have very dense needle growth on them. They capture snow in the winter, and then they shade that snow on the ground around them. And when all the other snow melts in the spring, there's still snow under these trees. And so it melts very slowly, and it provides a fresh water supply throughout the summer for all of the animals. So this tree, the white bark pine, is what we would call a keystone species. It's a species that helps hold the ecosystem together. That the survival of other parts, other entities in the ecosystem depend on the white bark pine. And when the white bark pine does well, the grizzly bears do well. So it's got this larger than ordinary impact on sustaining the system, which begs the question for me of what might some of the keystones be in a health information ecosystem? What are the entities or the organizations that could drive how ideas move through the system, or could improve the flow of information and resources in the system, or build capacity for other parts of the system? And selfishly, frankly, how can we at WashU Public Health either support other keystones, develop keystones, become a keystone in the health information environment? Let me look at another ecosystem that's a bit closer to the information space. And I'm going to call on you again to get out your phone. I've got mine. And I want you to open up your weather app of choice. Maybe it's one of the apps that you see here. And I want you to tell me what the high temperature in St. Louis is going to be tomorrow. So Thursday. Everybody got it? You guys are fast. I got 75 degrees. Raise your hand if you have 75. Okay. Anybody have 76? Okay, we got a 76. Your app sucks. No, I'm kidding. Anybody have 74? Okay, so think about this. In a big room full of people, all with different devices, probably many of us with different apps, just looked up information, forecasting what's going to happen tomorrow locally, and 99% of us got exactly the same thing. Had I asked you to go to your favorite health website and tell me what was at the top of the screen, do you think we would have got 99%? Think we'd have got 50%? Why is it that within the weather information ecosystem, there's uniform agreement about this data point? It's because of NOAA. NOAA is the National Oceanic and Atmospheric Administration. And among the things that NOAA does is collect data. And so NOAA has data from radar scanning the atmosphere. They have buoys in lakes and oceans that are checking water temperature and water levels and wave height. They have satellites that are looking at cloud cover and cloud movement. Did you know that when you fly an airplane, your airplane is constantly pulling atmospheric data about wind speed and other data and pushing it down to the ground to NOAA constantly across your flight? And NOAA has weather balloons, like hundreds of weather balloons that are capturing atmospheric data as well. And they share these data as a kind of public utility with local TV meteorologists and local radio meteorologists and app makers for our phones. And that's why we get near universal agreement about what truth might look like for tomorrow in St. Louis. So NOAA in the weather information ecosystem, I think, is clearly a keystone, and it's a public utility. Usually we think about public utilities as, this is the, the gas company or the electric company or the water provider, but public utilities are broader than that. Really, anything that provides essential services to the public that are in the public interest and operate with some degree of social responsibility can be seen as public utilities. And I think that we don't have anything like this in the health information ecosystem. But I think that at WashU, we are uniquely positioned to make contributions to the health information ecosystem. So I want to close today with two examples that I think illustrate this potential. The first is called iHeard. I hope that some of you are familiar with iHeard. It's now in its 5th year of operation. And I'll tell you just a quick origin story. So I'll take you back to January of 2021. The COVID vaccines have just arrived in St. Louis, and I get a call from the director of the health department at St. Louis County, a woman named Spring Schmidt. And Spring says to me, we've got people in these vaccine clinics out there, and they are just getting hammered with questions and accusations, and they sort of feel like they're false, but they don't know for sure, and they don't know how to respond to them. And on that call, we went on to devise a solution that would be listening to, very proactively, asking community members what they're hearing, and then rapidly converting that into information that we could provide back to frontline workers. And iHeard has evolved tremendously over the last 4+ years, but the fundamental approach of listening to the community, processing what we learn, and rapidly converting that into health information for the public has continued. So I just want to tell you a little bit about this. And one of the ways it's evolved is the funders at the National Institutes of Health really liked what we were doing in St. Louis and said, let's try it in other places. So iHeard has expanded to a total of 8 states, and we have been the national coordinating center helping those states to implement iHeard. Here's how it works. Every Saturday at 2 p.m., we push out a mobile phone survey. Short mobile phone survey takes 2 to 3 minutes to answer to 200+ community members here in St. Louis and in other communities as well. And we ask them questions to try to understand what are they hearing about health? What are they believing? What do they know? How much do they know? What don't they know? What questions do they have? And that survey stays open for 48 hours. We get remarkable response rates, 88% in St. Louis, 82% across all communities. And 48 hours after the survey goes out, we begin processing that information, and we identify the highest priority health information issue in each community. And we then do 3 things with it. The first thing we do is to share it on a public-facing dashboard. And that dashboard does a couple of things. It actually shares the responses so you can see over time whether people are hearing more or less about certain topics. But it also shows, shares, as shown in the green box here, accurate information, that if you were to hear this in a conversation, you would be able to respond with what is known about this. The second thing we do at iHeard is we create an alert every week. So you can think of this as a sort of press release, but it doesn't necessarily go to the press. It goes to community partner organizations like the ones that you see here, hundreds of them in St. Louis and elsewhere, to let them know this is what we're focusing on this week. This is what the community is hearing, knowing, doesn't know. Here's how you can help. And then the third thing that we do is develop digital social media assets like the ones that you see on the screen. And we share those with the same community organizations and other trusted local messengers so that they can share those with the populations that they serve. So we've been doing this in St. Louis, well over 200 consecutive weeks now, and in other communities for a year. And our main focus has been on feasibility, can we do this? And also spread, how does the information spread? Does it reach people that we want it to reach? I would say that on 3 of 4 sort of outcomes that we're interested in, we've demonstrated pretty terrific success. We've been able to establish this listening infrastructure through mobile phones in multiple communities and develop and deliver it consistently week after week for long periods of time. We've also demonstrated that we can process that information almost instantly and respond within 72 hours with concrete assets that we can put in the hands, share them with community partners. All of that, check, 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 we can do that. The weak link for iHeard, honestly, has been what's called the last mile. And maybe you've heard of last mile problems. And in the context of iHeard, what that means is we can generate all this information and listen to the community and put it in the hands of community organizations, but it doesn't always go very far from there. It doesn't always spread widely in the community like we would like it to. Think back to that first question I asked you when no one raised their hand to say that my local health department is where I get my information. My state health department is where I get my information. Part of the issue, I think, is that in trying to make this system highly localized, we're putting the information in the hands of organizations that have limited capacity to do this. And so let me tell you why that's a problem. And this slide sort of summarizes decades of health communication research in like 10 words. So take a moment to soak it in. But our goal for a project like this is to increase the odds that people, community members, encounter accurate information about a health topic multiple times, the more the better, from different sources that they trust. 2 is good, 3 is better, but that's when communication can have an impact. When someone hears the same thing from completely different independent sources that they trust. Does that make sense? So the challenge becomes, how do we increase the odds that that happens? And that's where we're going next with iHeard. So we are in a sprint right now to develop iHeard USA, which will be a national panel from folks across the country. And we plan to similarly use weekly surveys, but with a greater emphasis on open-ended questions so we can gather sort of greater depth of information about what people are concerned about and what they'd like to learn more about it when it comes to health. And we'll use that to generate what we're calling insight reports, and we're working on developing these right now. And our goal is to put those insight reports not in the hands of community partners per se, although we'll continue to do that, but content creators. People who wake up every morning and their job, they exist professionally to create health content. And what we want to do is provide a resource to them that's the health information equivalent to all of that NOAA data that they can build upon to address in their own way to their own audiences things that matter to the public and answer questions that the public wants answered and distribute those insight reports through industry partnerships. Why do we think this will work? First of all, like the NOAA data, I think we have distinctive information that is important and it's incredibly timely. Secondly, we've demonstrated already that we can exact really meaningful insights from data and we can do it fast. And if we put that in the hands of content creators, they can kind of organically do their thing with it, but it increases the likelihood that we have some kind of alignment or coordination between the topics that are being addressed and the time at which they're being addressed, and that would increase the odds of repeat exposure, which we're trying to achieve. Final example. How many of you have heard of 211? Excellent. Glad to see so many hands. We've been working with 211s across the country for 2 decades. 211, if you are just learning about it, is a 3-digit phone number like 911 for emergency. But if you call 211, your call is going to be answered by a live person who's sitting in front of a computer, and that computer is attached to a database, and that database has listings of all the health and social service resources that are available in your community. And those those resources are provided as referrals to the callers based upon what they need. The people who call 211, for the most part, just don't make enough money to live in modern society. They are disproportionately women, and most of those women have young children, minor children, living in the home with them. And they're calling for help paying the rent. They're calling for help feeding their families, getting food. They're calling to get a mattress for their child or other household needs. They're calling to find quality, affordable childcare or transportation. And what the 211 operators hear every day, every hour of every day, is unlike any sort of information about health and social needs that's collected anywhere in the US, and I think possibly anywhere in the world. And so 14 years ago, we launched an effort in partnership with these 211s to make these data much more powerful than they were. And this resource is called 211 Counts. And 211 Counts is a series of public-facing dashboards that report why people are calling 211 in over 100 locations across the country. I think we're in 44 or 45 different states right now, in near real time. If you were to go to 211 Counts today, you could see what people in your neighborhood, your zip code, called 211 about yesterday. So it's not real time, but it's pretty darn close. The dashboards, if you haven't been to one, look like this. And in the upper left, it describes sort of the main reasons why people are calling, and it's overwhelmingly housing in most communities, but you can see what that distribution looks like. In the upper right-hand corner, you can see kind of a further breakdown. Okay, well, within housing, how many people are looking for shelters? How many people need rent assistance? How many people need subsidized housing? In the lower left, you get kind of a visual depiction of how those requests are distributed by zip code across the coverage area. And down in the lower right, sort of kind of a time series look at the trends in particular needs. These data sometimes reveal remarkably powerful changes that are happening in society. This particular chart looks at the requests for food in almost 400 counties across the US in the weeks and months leading up to the COVID pandemic. So those short blue lines that you see are every day how many calls from those counties about food, and you can see there where the pandemic starts. And there's immediately after, within days, a cliff wall where requests for food, as people are being laid off and sent home, go up 4, 5, 6 times, literally overnight, and stay elevated for a long time. You might ask yourself, well, okay, that's an interesting finding, but sort of what good is that? Well, 48 hours ago, the federal government announced that it's no longer going to produce its annual report on U.S. food insecurity. So just as an example, as the government pulls back on information that it's sharing about health needs and social needs of Americans, a resource like 211 Counts becomes even more important than it was before, as perhaps the best indicator that we could follow. We worked with the Los Angeles Times a couple of years ago. They were very interested in what 211 might tell them about emerging issues, and they were particularly interested in the infant formula shortage. Do you remember this from about 2.5 years ago? Like out of the blue, like we don't have any infant formula, and like parents with infants are panicking. And we went back through the 211 data, and sure enough, we saw months ahead of time a 30% increase in calls about infant formula to 211s that were sustained for months and occurred months before this became a full-blown crisis in the public eye. Now, it's neat that we can look back and find that. Oh, look, it was there. But it would be much better, of course, if we saw it in real time and could do something to prevent it or reduce its impact. Similarly, The members of our team and the LA Times reporters went back a decade before and looked at the housing mortgage crisis of 2008. 8 months before the housing mortgage crisis, 211s were seeing 150% increases in calls about mortgage assistance. Can you help me pay my mortgage? And at the same time, even though it's not on this chart, at the same time, they were seeing declines in calls for assistance with home repairs. So people were stopped investing in their homes and were begging for resources to pay their mortgage. 8 months later, housing mortgage crisis comes. The signs were all there. We need to do a better job of capturing those, and that's where we're headed next. But just because kind of a quick summary, I mentioned we have over 100 of these state and local 211 dashboards. When you add them all up over the life of this project, as of July, we had 95 million social needs requests. Each of those, a person on the phone saying, I need help with. Do you think we could learn from that? Do you think we could gain some insights from those data? And these dashboards are getting visited millions of times as well. So what we'd like to do moving forward with 211 counts is making much more sophisticated use of data science and AI, including things like aberration detection, like the examples I showed. Like can we pick up like a 25% increase that's sustained over time? Can that raise a red flag in the same way that public health surveillance does? Looking at spatial analyses, where are some of these issues most prominent? The weather forecasting that's being done with NOAA data is an example of what is called kind of nowcasting, merging immediate data with past models to identify what precipitation chances might be. But it could also apply to the work here with social needs. And then just in general, improving the social service system, which is not all that efficient. And can we use this information to make service improvements as well? So on top of all of that, we need to find better ways to share this information from 211 counts to inform decision-making and resource allocation in communities. What I heard and 211 counts share in common, I think, is they are capturing what military folks would call ground truths. They're out there in the real world listening to people. In the case of I Heard, weekly surveys. Tell me what you're hearing. Tell me what questions you have. In the case of 211 counts, literal calls for help. I need help with X. I need help with Y. These are firsthand reports. And I think that those sorts of data get back to where we started in this presentation by answering what's the problem and at least who has the problem. And our approach moving forward is to try to package that information in a way that's useful to people who can answer the fourth question of what can we do about it. To provide that information to content creators, decision makers, those who allocate resources to inform what they do. So thank you very much for attending and listening. This work is the product of a lot of people, many of them in this room. Thanks for coming. I just want to really acknowledge and thank them for making all of this possible, and I'd be happy to take questions. Rebecca, do we have a microphone? Hold on, we have a microphone coming your way.
So, Matt, that was fantastic. I learned a ton. And I guess my question has to do with the relationship between federal and local in this endeavor. And, your important example of NOAA, which has been defunded. There's been a cut of weather research, massive staff layoffs, and 211 is, of course, authorized by the FCC. And I am wondering, how do we insulate these endeavors from a uncooperative, maybe, unreliable federal partner in this moment? And yeah, how are you thinking about that?
Yeah, great question. Thank you. I'll tell you how I'm thinking about it, and I believe others in this health information ecosystem space are thinking about it this way as well. Take, for example, the sort of the elimination of the communication offices within many of our federal health agencies. So people who are doing public health on the ground have lost kind of a single authoritative source of information that they can trust about health and recommendations. People are trying to figure out how to fill that gap. The federal agencies that you describe and others are also like they are not generating the same kinds of information for the public that they have historically, and that's a gap. And other players in the health information ecosystem are trying to fill that gap, racing to fill that gap, honestly. And so I think, viewing this as an opportunity, I think it's pretty clear. Like there's a chance here to, for different players and different entities to assume new roles. And to be candid, it's not like, it isn't as though the state and local and federal health information apparatus was some sort of a shining star. Like, I mean, it had plenty of blemishes to begin with. And so this is a chance to, rethink and reinvent some of those functions and have them assumed by others. And I think that's good for us, here at this institution, that I think we can play a role.
Hello, my name is Chisom, and I had a question about how you plan on regulating the content creator aspect of it to prevent malinformation, because there is so much diversity in social media content creation right now, and it's just something to know because some of them actually read the data and then still come and say for like misleading information of this data they have gotten from a credible source, making it look like, oh, I know what I'm saying, but still it's, translating like some form of malinformation, disinformation, or misinformation to the general population.
This is a fantastic question, and I'm gonna frame it. I'm gonna give you kind of a concrete example, and then come back to kind of more broadly how we think about it. How many of you have heard of wastewater monitoring? Good, you're in public health, you should. So basically, public health agencies, mostly at the local level, but sometimes at the state level, they're actually testing water, wastewater, water that comes out of people's houses, to see what's the viral, sort of footprint in that water, to understand if certain diseases, microbes, flu, influenza or COVID, are increasing or decreasing in a community. We surveyed and polled on this, and one of the things we found was that the public knows just about zero about this, okay? And we could share that information and publish that, and we did. But if you're someone who is working in the area of malinformation, as you said, or misinformation, that's the perfect opportunity for you. When the public doesn't know anything, you can grab it and lie to them. You can grab it and tell them, oh, well, this is the government, intruding on your privacy, right? And so, like, that's a very concrete example of how sharing information widely could be used by bad actors to advance a different sort of agenda. I don't know how to prevent that. And I would say that the approach that we are taking is to try to provide information to the community of content creators and trust that they will do responsible things with it. And They may not. Some may not. And we may have to make adaptations or modifications to what we're doing. But I think the hope would be that you get enough uptake from enough people that it helps to minimize or diminish the bad actors. That's not a totally satisfying response or strategy on our part, but I guess I would also say that one of the things I've learned from doing this work over many decades is that if you try to perfect something before you go out with it into the world, you never go out into the world. And I just trust our ability to be able to adapt on the fly. And once we figure out how people might be misusing the information, we can try to come up with ways of reducing that. Thank you for the question.
This is a question from online. It says, this is not so much a question, but perhaps a suggestion. Have you considered involving college students or campuses in the form of student groups or chapters of iHeard?
Really interesting question. We were approached by a university community in Wisconsin that wanted to do this. It was going to be a student project to launch iHeard in their community. And then their funders decided that that wasn't a priority for them. But I like the idea, and I'd like to hear more about it. And so I would encourage that person, whoever provided the question, to reach out to us. Yes.
Thank you. I wasn't sure where the microphone was going. Thanks so much, Matt. This was really interesting. I wanted to ask if you've done anything with any internet companies or AI-related summaries that come up on searches, because so many people raise their hand for internet as one of the sources of their primary sources of information. And you're feeding a lot of information to these places where people are calling, but what about online? And if you've connected with anything that's been successful?
So is the question like sharing our information with online sources, or maybe you can restate
Yeah,
that?
so I guess
Sorry.
a couple of people in my lab have looked at what kinds of misinformation comes up when you search for a common topic in order to put information that responds to that into an evidence-based tool.
Right.
So you're doing that with this iHeard and also with 211 to kind of rapidly respond to things people are hearing. But what about things people are reading from AI summaries that come up right up top when someone searches for that health information?
Yeah, it's interesting and clearly a really important kind of activity. I don't think we've done much with that. I would say that the way we've been exploring AI mostly, and other members of my team here, I'm looking at you, Hannah, have probably thought about this more than others, but we've definitely looked at and considered whether what would be the role of AI in identifying information that's circulating, at least in online spaces, not necessarily reaching people in communities. We've also looked at AI as how it might help us to rapidly process open-ended data. And honestly, we've been pretty unimpressed with that so far, but it will improve probably. We haven't used AI for content creation for like the things that we create. So I think it's a good idea. I'm glad your team is looking at it, and hopefully others are thinking about it as well. We had a question down here.
Hello. Since there are like parts of the population that might just go to the doctor once a year for a physical, or might just go like to health facilities or not go ever, and there are also parts of the population who don't use social media, where is that gap being bridged? Like, are you all's community partners also with like faith-based organizations, grassroots organizations, stuff like that?
Yeah, so two answers to that. The most direct answer is that this was one of the things we learned when we rolled out 211. So speaking about like, kind of constant learning and process improvement. And we learned that there are a lot of folks who are not ever going to see this stuff on social media, and they would never even, they would never encounter it, and the people that they trust would never encounter it. And we heard this from community organizations and partners, and so we moved to create different versions of this. So we also create, and I didn't mention this in the talk, but printable versions of all of these assets that can be distributed by hand by faith organizations and other organizations that interact with people sort of face to face. The other point I would make, and I didn't emphasize this and probably should have, this whole project, the I Heard project, from the outset was designed to support community responses to COVID in the populations that are disproportionately affected. So if you would look at sort of the composition of our community panels that we're listening to, they overrepresent groups, they overrepresent the groups that bear a disproportionate burden of health problems. And that was very intentional, and that's true in all of the communities that I Heard has been in. And I think that's been really valuable. And we've learned so much because we can also look at these insights every week, not just overall for a community, but within subgroups of a community. And we can see sometimes that this group is hearing something, and this group is hearing something else. And it doesn't always go the way you would think. So it's really valuable to have that as kind of baked into the project.
All right, thank you so much. With that, I think we're going to wrap up for the day. Please help me thank Dr. Kreuter for this really insightful talk.